Okay, what I want to do is briefly talk about the background of the project. As Jeff indicated, a key element of it is to help evaluate the implementation of the Framework Convention. Why do we want this particular project in Southeast Asia? What are we doing? And what do we expect to learn? The original ITC study, as Jeff said, has cohorts in 4 countries. We now have 3 waves of data from those cohorts, and we're learning an enormous amount about the impact of tobacco control policies. However, a limitation of that study is it's the study of largely affluent, largely English-speaking cultures, fairly similar cultures on a world scale. And the question comes is, what is the generalisability of the findings we get from those 4 countries to quite different countries? So why have we got the Southeast Asian project that our TTURC funding has allowed us to put into the field? Do the policies that work in the 4 countries work in countries that are culturally disparate? If they do work, are there differences in the way they work or in their relative efficacy? If there are differences, what characteristics of smokers are responsible for any differences that we might find? Also, Thailand and Malaysia may just start things in tobacco control that haven't occurred in the countries that we're studying. So if they do novel things, we want to be the first ones in there to find out whether they work or not. There are big differences, as I indicated, between the countries Malaysia and Thailand. There are quite big differences between Malaysia and Thailand, but collectively they're very different to the other 4 countries. First of all, they come from a tropical rather than temperate climate zone. And this has particular implications in environmental tobacco smoke or passive smoking issues. Languages are different. So there are challenges of languages, there are challenges of the nuances of languages and things like that. They're middle income versus high income countries. Does that make a difference? We don't know. Religion is very central to the lives of most of the people in both of those countries, much less so than it is, at least in the majority of the countries we've been studying so far. These countries have a collectivist versus individualist orientation. We heard some work on that yesterday, indicating the importance of these factors in influencing what might happen in terms of the interventions. And there are major gender differences. We've heard a lot about the fact that few women smoke in Asia, but what are the implications of that? And it's quite different to most of the countries we've been looking at. So what are the design features of this study? Currently we're funded for 3 waves, surveying 2 yearly, but however we're seeking additional funds to make this surveying annual, because we believe that we need to get annual surveying if we're really going to pick up many of the nuances. We have multiple respondents from one household. One of the things that we found in Malaysia and Thailand is that there wasn't sufficient spread of telephones to be able to do telephone surveys, so we have to do face-to-face surveys. As a result of going in face-to-face, we actually have multiple respondents from the one household, an adult male smoker if there is one, and an adult female smoker. We've done that to maximise the number of adult female smokers we get in the survey. We're also, where possible, surveying an adolescent from those households, plus from some non-smoking households, 13 to 17, regardless of smoking status. We're doing careful household enumeration to assess prevalence, and we have a random sample. I mentioned the first few of those. We're doing this as clustered sampling, which is inevitable in household sampling. We've taken a random sample of areas within the country and then gone down to a district level and then to collector districts from which the samples have been taken. One of the most exciting things about this project in terms of its extension is we have an adolescent cohort who will include both smokers and non-smokers. And because we have data largely on their fathers, because most of the mothers don't smoke, we're in a unique position to link the behaviour and attitudes of the father to the smoking behaviours and inclinations of their offspring. The other exciting thing is that we have an extremely exciting collaboration with the Malaysian Ministry of Health, who've joined with us in this project. They're interested in the evaluation of their large mass media campaign, which we're going to hear about in a minute, and they've joined with us, shared resources, and as a result of that we also have a non-smoker adult cohort, which is again increasing the capacity of this study. The research questions are similar to those in the other countries. We want to understand more about these smoking in these countries because much less is known. We want to contribute to anti-smoking campaigns. We want to look at the impact of graphic health warnings in Thailand, which are just coming in, and we'll hear a little bit about that in one of the presentations to come. We're interested in exploring the role of religion, of collectivism, of ETS controls, the effects of restrictions on promotion, which are very tight in Thailand, for example, and also effects on price. Presentations to follow present very early data. We were funded on the 1st of September as an overall project, but the money, we couldn't actually release money into our Southeast Asian team until early this year. Yet we have managed to get into the field and collect all our data. We had it all entered about a week or so ago, and these are very, very preliminary data. The two teams we've had working with us in Malaysia and Thailand have just done an absolutely extraordinary job to do these complex surveys all in a period of about 2 months, get all the data entered and be able to present some coherent, analysed data to you today. I'm looking forward to, and I'm sure you will be, to hearing some of that data in the next two presentations. Thank you.